Hi, this is Mary Sir, coming to you again with part 4 of the Nurse Revenue series. This series is about remote physiologic and therapeutic monitoring. Let's get started. Remote physiologic monitoring codes have been around for a while, but they usually require that the device be able to transmit data automatically. So it narrows, obviously, what you can use to having a device that can do that. There are codes for the device deployment. There are codes for collection and interpretation of data, and there are codes for treatment adjustment communication. And then as of 2022, they added the therapeutic monitoring codes. And this really opened this code set up for a lot more specialties because now you can have patient reported data. So there's a device deployment CPT code range if you have a device that needs to be deployed. However, you can also get data from the patient self-reported to be able to make changes to the adjustment plan. There are also a few more specific monitoring codes that we can share with you, but it really does start with what you want to monitor for your patients. So start thinking about with me some of the things that you would like to monitor in your practice. In this day and age, there are all kinds of things that we can monitor now, but it's really important that you understand what you're monitoring and how to document it. So here's an example of a patient that is utilizing a remote physiologic monitoring program. Andy is an asthmatic patient who has been prescribed a remote physiologic monitoring system to track frequent spirometry results. He comes into the office to pick up a smart spirometer. The nurse helps Andy download the monitoring app on his phone and teaches him how to use the spirometer and app to send data to the office. Andy uses the spirometer for 60 days. After the first 30 days and then again at 60 days, the provider reviews the data transmissions and adjusts the plan of care. The nurse calls Andy after each change adjustment and talks about the data and care plan changes for 25 minutes each month. Now, all in, we're talking about a CMS reimbursement of $231. So, how do we get there? So, there's a code for the device setup and education, which is 99453. And this is something a nurse can do based off of a provider prescription or order. There's no RVUs associated with it because it's usually nurse work, and CMS reimburses $19. The device utilization is per month. So it is the cost for the equipment utilization that you have. It's $56 per month. Again, there's no RVUs because there's no physician effort at that time. The last code is the management and treatment plan changes. And this is for the reimbursement for provider time and evaluation and nurse time in communication. And this is worth 0.61 RVUs, and CMS reimburses $50 per month. So if you look at Andy's example, Andy was in a program for 2 months. So all of that added together is $231 from the Medicare fee schedule. This table outlines the parameters for use of the remote physiologic monitoring codes. You can see there's a line for service captured, frequency, time commitment, interaction with the patient, and whether it's part of a care plan. You'll notice on that last line, all of the answers are no. And that means that you can bill this physiologic monitoring in addition to care management as long as the minutes are delineated as separate in the medical record. So if you go across the columns, you'll see that first code 99453 for the setup, 99454 for the equipment utilization. There is a physician interpretation code 99091, and the treatment management codes are 99457 and 458 based off of the time spent. So you'll notice in the last example, I did not put down CPT code 99091 for physician review and interpretation. That is because it requires at least 30 minutes per month, and that was not clear in the example. So if the provider is reviewing the data and spends an aggregate time of 30 minutes per month reviewing this data that's downloaded automatically, you can bill that code, again, separately to any of the other codes, as long as the documentation is present. Just a note about documentation requirements, you do need to document the device deployment, including the nurse education given. So this can be in a nurse ancillary note if you want to. Most of the time I have seen that it demonstrates competence, that the patient is able to tell you how to download the data so that they can use the device appropriately throughout the month. You have to have a minimum of 16 days of data. You should not build this code on the same day as an E&M code or other care management code, but they can still be built together if the minutes are distinguished. So all of these can be part of a greater care plan for the patients. This is just one piece of it. daily transmissions of data straight to the EMR and not self-reported. So that's a very big deal. It does limit the devices that you're able to use for this. You need to be able to store the transmissions in your EMR product. And then finally, at least 20 minutes of patient communication a month for that management code set. You don't have to build the management code set every month, but if you do communicate with the patient, that's what's required. You can put it in a telephone note or an addended progress note if your EMR accepts it. You must document the date and minutes spent. Again, you want to be very specific with that because if you also have a care plan and communication that way, you're going to want to make sure that it's distinguished in the record. Here's a note about that CPT code 99091 for the physician or APP interpretation code that you can bill monthly. So this is, again, for physicians or APPs only. It's the amount of time they spend collecting and interpreting the data. So this is really where the physician work comes into play when you're looking at these monitoring codes. It must be a minimum of 30 minutes a month. CMS reimburses $56 and it has 1.1 RVUs. So you'll see out of the whole code set, it has the most RVUs of anything because this is the most physician or APP work effort in the code set. This code is also covered where other CPT codes may not be, again, because it is physician or APP work as opposed to work done by ancillary staff. But ideally, all the code set would be in with your managed care contracts. It does not require time-based communication, but does require some form of communication. If it's an email or a message or something like that, there is a requirement that there be some kind of communication to the patient. This code also bundles with that treatment management code. So that's the big deal, and that's the reason why you're going to have to choose either or. If the physician or APP does not spend 30 minutes a month, but the nurse spends time talking to the patient, then you would go with that treatment management code 99457, 99458. If the physician does spend at least 30 minutes a month reviewing this data, this is the code I would go with because obviously it has more RVUs and it also carries more reimbursement and is accepted by more payers. In 2022, the AMA came out with a new code set for therapeutic monitoring, which is very similar in concept to physiologic monitoring, but answers the question, is what we're doing for the patient working, as opposed to establishing a diagnosis or determining the severity of a diagnosis. So why did they come up with this code set? I think that in discussions, there was a need to evaluate non-automated data in response to treatment. And the best way to do that is to talk to the patient and see how things are going. So the patient does need to write down whatever you're monitoring daily, and that you need to be able to speak with the patient frequently to see how things are going. But it is qualitative data, not quantitative data. RPM requires data that cannot be self-reported, so it was very limited in utilization. So this opens up the code set a lot more. The setup codes for RTM are for respiratory and musculoskeletal devices, but that doesn't mean that you can't use other kinds of devices or, again, talk to the patient for the management and treatment part, which is the most important part. Right now, there's no equivalent for 99091 for self-reported data, and you'll see that in the parameters. I think the closest code is 99358, which is the indirect prolonged services code when the provider is spending 30 minutes or more outside of patient care. I think that's the closest comparison that we have right now. So let's look at an example. Here is a patient example of the remote therapeutic monitoring codes, again, which are new for 2022. Betty is 100 days post-op from a total knee replacement surgery. She's struggling with pain and ambulation. She comes to the office to get a wearable motion sensor from her surgeon. Betty uses the sensor for 120 days. Each 30 days, results are downloaded, and she also self-reports pain level and ease of ambulation. The provider collects and interprets the results and shares the plan of care with his nurse. The nurse calls Betty and spends about 30 minutes each month on the phone with her discussing the care plan changes. Total reimbursement for this example is $337. So again, how we get there. So the device setup in education is CPT code 98975. Again, a nurse would perform this service based off of a prescription or an order from a provider, physician, or APP. There are no work RVUs, and CMS again reimburses $19. Again, with this code set, you don't have to have the device deployment. You don't have to have something that automatically translates data to the system. It is just an option. And they usually limit it most of the time in the CPT code set to musculoskeletal and respiratory devices. The device utilization is the cost per month. Again, it's $56, just like with the physiologic monitoring. And then the management and treatment is that reimbursement and provider time for education and treatment care plan changes. And that does have 0.62 work RVUs, and CMS reimburses $50 per month. So if you're talking about a 4-month case example, that's where you get up to $337 total. Just like with the RPM codes, here are the parameters for the use of the RTM codes for treatment. You do have a service captured, frequency, time commitment, interaction with the patient, and plan of care rows. And again, you'll see that this also is not included in part of the greater care plan as long as the minutes are distinguished. You have the technical component of the setup of 98975. The equipment is 98976 and 77. There is no comparable CPT code to that 99091 data evaluation code. I think the closest thing is 99358, which is indirect prolonged care services, which requires a minimum of 30 minutes a month, not in face-to-face contact with the patient. So that is the code that I would use as a comparable code. And then you have the treatment team communication, which is 98980 and 98981, usually done by the nurse based off of time. So there are other more specific monitoring codes out there. These are just some examples. They have apnea monitoring, glucose monitoring, blood pressure monitoring in 2 different forms, which is obviously something that is monitored quite frequently. So it's important to know your specialty and know what codes are available before selecting the most appropriate one. How to start using this code set. The first thing I would do is gather your team together and use slide 3 as a jumping off point. What do you want to monitor in your practice, and what device to use to best get those results? The next thing is how to document and bill in your EMR system, and this can be quite tricky. The reason why is that these codes usually don't have a scheduled visit or an encounter, so it's really hard to tie charges to them. So you have to go into the billing concept with that in mind, that there really isn't an appointment or something that you're going to be able to close the note, open a charge navigator, however your EMR system works. You will have documentation. It can be a telephone encounter, it can be a progress note, but you need to have the ability to enter a charge when you don't necessarily have an appointment. And that can be a workflow back to a biller or a coder, or it could be building your EMR system to allow for that. And then finally, I would create literature for your patients to review about what these codes require on their parts. What are they going to have to do? Again, you can use this as part of a larger care plan initiative, and you can bill both minutes, but it's important that the patient knows what to expect and really how it's going to benefit them. I don't think it requires a huge kickoff, even though this is something I'm sure you guys are doing all the time. I would just inform the patient that this is something that you're going to be documenting and gathering and submitting to insurance so that there is consent. So this is a very new code set. I'm sure there are a lot of questions. If you have any questions at all, feel free to email us at question@m2revenue.com. Thanks for watching.